Good morning, everyone, and welcome to the webinar, Public Health Genomics in Practice, Hereditary Breast and Ovarian Cancer in Public Health. This webinar is co-presented by the American Public Health Association Genomics Forum and Genetic Alliance, and we have a whole host of great speakers with us today. This session will be moderated by Summer Cox from Oregon Genetics Program and Oregon Health Authority, and Andrew Sardella, a genetic services specialist at Washington State Department of Health. I'm James O'Leary from Genetic Alliance. Let me introduce the background of this webinar. So this webinar is a continuation of a series of webinars on public health genomics applications. The first webinar reviewed overall Tier 1 applications, and then we'll have 3 webinars in this series focused on hereditary breast and ovarian cancer, on Lynch syndrome, and on familial hypercholesterolemia. This webinar series is to highlight the advances in state public health departments as well as nationally. And we've had many great partners involved as part of the Genomics Forum. Andrew, are you on the phone, or Summer?
I am. Yes.
Okay, great. So I'll turn things now over to Andrew.
Thanks, James. Hi, everyone. My name is Andrew Sardella. First off, I want to thank everyone for attending today. We've got a great webinar in store. So as James had mentioned, this is part of a series, and today's webinar is focusing on hereditary breast and ovarian cancer. So I want to just introduce all the members who are involved in today's webinar. Co-facilitating with me today is Summer Cox, the Oregon Genetics Program Coordinator. And also you heard from James O'Leary, who is the Chief Innovation Officer at Genetic Alliance. We have a great panel of speakers today, including Cecilia Belcross, who is the Director of the Genetic Counseling Program at Emory, Tua Paul, who is a board-certified clinical geneticist at Moffitt Cancer Center, Virginia Warren, the Director of the Arizona National Breast and Cervical Cancer Early Detection Program, as well as Sue Friedman, who is the Executive Director at Facing Our Risk of Cancer Empowered. So today's webinar is filled with a lot of great information that I know the attendees will walk away with. Here we have just a few of the objectives listed, including highlighting real-world examples of successful programs in addressing hereditary breast and ovarian cancer syndrome. You're going to hear about several available screening tools and other resources related to HBOC. And then you're going to hear from a lot of different perspectives on the topic, but including patient perspectives on the importance of identifying individuals and families with HBOC. So at this time, I guess I will turn it over to our first speaker, Cecilia Belcross.
Okay, well, hello everybody. I'm going to try in just a few minutes to tell you everything you need to know about hereditary breast ovarian cancer. So it's going to be a bird's eye view, but hopefully give you a feel for why it's important to identify women who may be at risk for carrying a mutation in BRCA1 or 2, and the potential benefits and public health positive outcomes that can come from that. So just overall, breast cancer, as you know, is common. 1 in 8 women will get breast cancer over the course of their lifetimes. The vast majority of those are what we consider sporadic. That means there's very little, if any, inheritable risk. Then there's familial, where we might see more breast cancer than we would expect by chance, but not real strong from an inherited standpoint. And those women typically are maybe 2 to 3-fold general population risk. So the minority of breast cancer is what we call hereditary, and that means the person inherited a mistake or a mutation in a major cancer susceptibility gene. So most of you have probably heard of BRCA1 and 2, at least through Angelina Jolie. If we look at all breast cancers, though, only about 3 to 5% of all breast cancers are due to an inherited BRCA1 or 2 mutation. However, if we look at ovarian cancer, and then we include fallopian tube and primary peritoneal carcinoma, in that definition, 15% or more are actually due to an inherited BRCA1 or 2 mutation. So you can see this does account for, given the whole population, a substantial number of individuals. This pedigree just shows what can happen in a BRCA1 or 2 family, multiple generations affected, early ages of onset, individuals with bilateral breast cancer, and also emphasizing that it can be inherited through the father. BRCA1 and 2 mutations are inherited in an autosomal dominant fashion, and that means each child of an individual who carries a BRCA1 or 2 mutation has a 50% chance to have inherited the same mutation, but also a 50% chance that they did not. So what do we look for that signal possible HBOC or hereditary breast ovarian cancer? So definitely early age of onset of breast cancer, under 50, but keep in mind that definitely not all BRCA1 or 2 related breast cancers occur under 50. Ovarian cancer is a very strong indicator, and again, thinking broadly with respect to fallopian tube and primary peritoneal. A woman, particularly under age 60, who has ER/PR and HER2 negative breast cancer. Whenever you see multiple cases of breast cancer, particularly in the setting of also a case of ovarian cancer on the same side of the family, whenever breast and ovarian cancer occurs in the same woman, that is a very, very strong marker for BRCA1 or 2. Bilateral breast cancer, particularly when at least one is under the age of 50, so that's separate cancers in both breasts. Male breast cancer, which is quite rare in the general population, but it is substantially increased in men who carry BRCA1 or 2 mutations, and is a signal there might be HBOC in the family. And then individuals of Eastern European or Ashkenazi Jewish descent have a much higher likelihood to carry a BRCA1 or 2 mutation. So this is just showing you general population, if you're Jewish, the likelihood of carrying a mutation, and then depending on age of diagnosis, family history, and so forth, the likelihoods of BRCA1 or 2 mutation increases. So what does it mean to carry a BRCA1 or 2 mutation, or to have inherited one? Well, clearly the risks for breast cancer are substantially increased above the general population. Early on, we were quoting risks in the range of 85, 87%. Now, with much larger population-based studies, we find that not all families, the risk is that high, and it ranges in between 40, 50%, in some families as high as 85. You also see a substantial increased risk for second breast cancer. And then ovarian cancer, which occurs in less than 2% of the general population, again, a more than 10-fold increased likelihood for women who have BRCA1 or 2 mutations. And then male breast cancer is increased more with BRCA2 than BRCA1. And we also see other cancers in these families increased modestly, pancreatic, melanoma, particularly early onset, and more aggressive prostate cancer. So what do we do about it? These are substantial increased risks. We have the capability of initiating screening and prevention options that can dramatically reduce the morbidity and mortality associated with inheriting a mutation in one of these genes. And it's pretty powerful when you're working with a family where multiple generations of women have died young of cancer, be able to intervene and change that pattern in the family. So you can see it's definitely different than the general population. We begin by age 25. Breast MRI is recommended for women under the age of 30, as it's better for younger women with denser breasts. The CA125 and transvaginal ultrasound are screening tools for ovarian cancer. Unfortunately, they're really not very good, and we're not sure they're helping at all, but it's what we have at this point. Tamoxifen can reduce the risk for breast cancer, particularly in BRCA2 carriers, and use of oral contraceptives can reduce the likelihood of ovarian cancer by 50% with a minimal to no effect on breast cancer risk. This is just showing you the importance of breast MRI. These cancers, in particular BRCA1 cancers, just do not show up on mammogram as well. The American Cancer Society recommends breast MRI now for women at increased risk, including those who carry mutations. Right now, the most effective management options are preventive surgeries. So removing the breast reduces but does not eliminate incidence of breast cancer in this population. Probably the strongest recommendation we have is for preventive removal of the ovaries and fallopian tubes. This is because, as I mentioned, we have no effective screening tools for ovarian-related cancer, and it tends to present at late stages and has a low survival rate. And also, though, if performing prior to the age of menopause, we can also reduce the incidence of breast cancer, and we've shown as well that we reduce mortality related to breast and ovarian cancer. So this is showing a family and how genetic testing might be important to them. So we have 2 occurrences of breast cancer under the age of 50 and 3 generations affected, so it's suspicious. If we test Bonnie and she carries a mutation, then that's important information for her because she's at increased risk for second breast cancer and ovarian cancer. But we also know at that point that Sarah is at 50% likelihood to have that mutation. If she is negative for the mutation found in her sister, then her risk is not greater than anyone in the general population. So genetic testing can identify not only who is at risk and needs that intervention and screening, but who is not at risk and can avoid unnecessary interventions and potentially anxiety. Genetic counseling is a key process of undergoing BRCA1 and 2 testing, and there are many aspects that need to be considered in terms of the medical family history, appropriateness of testing, but really making sure that the patient is making an informed decision on testing and how to deal with those results and what it means for them. And in addition, dealing with the psychosocial implications for management and screening and for family members, etc. So the United States Preventive Services Task Force recognized both the benefit of testing and the need for genetic counseling in their 2005 recommendation. Receiving genetic counseling for women with a family history of breast ovarian cancer is also a Healthy People 2020 objective. The Commission on Cancer has in their standards risk assessment and genetic counseling is required to be credentialed by the Commission on Cancer. And then the USPSTF updated their recommendation, reaffirming that women with a risk for a BRCA1 or 2 mutation should receive genetic counseling and based on that counseling genetic testing. But they also indicated there needs to be screening tools to help identify those women at risk. This is such a screening tool. It was developed and validated by myself, and then an updated website was provided as part of a CDC cooperative agreement with the state of Georgia. And I'm going to click on this real quickly, and we'll jump in on the general public. We're accessing the screening tool, and you can see it connects with information on HBOC, resources, counseling, and so forth. And this is how simple it is. It is a series of 6 questions, and depending on your answer to those questions will determine whether or not you meet criteria for potential increased risk for a BRCA1 or 2 mutation. And what you see is we're asking about number of breast cancers under 50, et cetera, and so forth. And that provides a printable result that the individual can share with their clinician and hopefully then be referred appropriately. This is, whoops, next slide. Sorry. This is just showing the validation, and it was validated with 4-generation cancer pedigrees against very highly specific models and has a pretty good sensitivity and specificity and overall accuracy. So in summary, this is an important public health issue. 1 in 400 individuals in the general population and about 1 in 40 individuals of Jewish descent will carry a mutation in BRCA1 or 2. So that's close to 1 million individuals across the country, the vast majority of which have not yet been identified. We have demonstrated very clearly that interventions can be life-saving and reduce morbidity and mortality. But again, once you identify an individual who carries a mutation, you can then use that information to identify family members who carry the mutation and are at risk or who do not. And that's considered cascade testing and something strongly recommended by the CDC. So I'm going to end there, and I'll be happy to take questions at the end.
Okay. So thank you to the organizers for giving me the opportunity to present at this webinar. Basically what I'm going to talk about are some inherited cancer initiatives in young black women with breast cancer that we've pursued in our state. The whole reason we went in this direction is we had figured out many years ago that young black women compared to white women have both a higher incidence of as well as higher mortality from breast cancer. And given that one of the hallmarks of a BRCA-associated breast cancer is young age of onset, we thought that BRCA mutations might account for a small proportion of these. So what we did was we started out conducting a population-based study, both to estimate the access to BRCA testing services in a high-risk population. So these were all women diagnosed at age 50 and below with invasive breast cancer who were self-reported to be black in the cancer registry. And we also wanted to look at the frequency of BRCA mutations in this population. So looking at our recruitment methods, we obtained information directly from our state cancer registry, which is called FCDS. In participants or potential participants, we sent an informational package alerting them to this study. In those that were interested, we sent them enrollment packages. We secured informed consent, got medical record release signed, and got them to complete a questionnaire. Then we provided them with a genetic counseling session, so pre-test genetic counseling, after which a specimen for DNA extraction was collected, and on which we did the BRCA testing. So what we figured out from this, we had a questionnaire that was filled out from the outset. And from this questionnaire, what we were able to determine was about 50% of them had accessed genetic services. And by genetic services, I mean genetic counseling, genetic or referral to genetics, or genetic testing. But there was about 50% that hadn't accessed services. And these are all, per NCCN guidelines, eligible to be referred for genetic counseling. Of these, what we looked at is, various people attended sessions, various people were referred, various people had genetic testing, but when we looked at actually who was referred, attended, and counseled, and tested, it was only 15%. So again, I think, speaking to Cecilia's point, we can do better here in terms of providing these individuals with better standard of care services or per national guidelines. When we looked at factors associated with BRCA testing, what we found in our entire sample was about a third of our sample had BRCA testing. So we looked to see, okay, well, what were the factors that were associated with access? So we found people with private insurance were more likely to get the test. Income was also positively associated, as well as age, meaning the younger the individual, the more likely they were to have accessed genetic testing. When we looked at mutation frequencies, and what we found in our first 284 participants, we have about 400 total, but when we analyzed the data based on 284, 28 had BRCA mutations. But again, less than age 50, all comers, it was almost 10%, which is very high compared to what we see in other populations, the general Caucasian population in particular. And again, what we found was the younger the age, the more likely there was to be a mutation. When we subdivided by BRCA1 versus BRCA2, what we found was with BRCA1, we did see this age effect where the younger the age, the higher the likelihood of a mutation. But with BRCA2, it was pretty even across the board. So I don't know how great a predictor age is with BRCA2 compared to BRCA1. Just going through a few cases where of individuals where we found mutations, this is about 10% of our sample based on the first 284, what we found was BRCA1 carriers tended to have a stronger family history compared to BRCA2 carriers. We found, I mean, this is just one double mutation carrier, but we had a few double mutation carriers who had mutations in both BRCA1 and BRCA2 and had not been referred to services in the past. And then another one who'd had bilateral breast cancer at an early age, had Medicaid insurance and had tried to actually access testing, but could not because of the lack of insurance, and then subsequently underwent double lumpectomies as her breast cancer treatment. So as a result of our research efforts, that's what has informed our outreach and education efforts. So we're kind of coming at it from a different angle, where the research actually was where we started from, and then we realized there was this need in the community for more outreach and education. So we started this effort that we call the Be Great Initiative. And it's an initiative to address disparities related to hereditary breast cancer in Black women. And the T really is for team, because almost 10 years ago we had partnered with several members of the community, who we call our Community Advisory Panel, who have really been instrumental in our research efforts, but as well in our education and outreach efforts. So again, just to kind of give you a sense of how this all started, when we had initiated our research studies, we wanted to develop culturally appropriate recruitment material. So we developed this study brochure through individual interviews to make sure that we were doing it right. And what we found was our Community Advisory Panel, as well as our participants, loved this brochure and they wanted to distribute it. But this was for targeted recruitment, so it's really not appropriate to distribute it widely. So we went forward and we developed a brochure that really is focused on increasing awareness about inherited breast cancer in Black women in general. And again, it was dictated by the needs that were brought to us in terms of what people wanted. In terms of current Be Great outreach and education projects, we have been actively disseminating our brochure as requested, and it is available freely from us. We have developed a website which has some information on this inherited breast cancer. We do attend community events and provide speakers. We've been doing that over the last year or so with some funding that my colleague Dr. Susan Vadaprampel had received through the Florida Breast Cancer Foundation. And we developed a Florida Breast Cancer Support Group directory. And again, this was dictated by, we started doing this because our participants that we had recruited statewide through our research study really wanted to know what other support there was for them. So again, we identified a need and went forward and developed something that could hopefully meet some of this need. Looking at the lay brochure, we have disseminated it to over 25,000 people to date, mainly in Florida, but beyond as well. When we look at where we've distributed it within our state, what we found is it looks like we have been successful in distributing it in the areas that have a higher proportion of Black populations. I was also asked to talk about funding. So how do we get these kinds of efforts funded? So ours have really, the way we started off was through external peer-reviewed research grants. And the grants that we got included Komen for the Cure, Florida Biomedical, as well as American Cancer Society, both National American Cancer Society as well as Florida American Cancer Society. We have gotten one grant focused on outreach and education, and that was a small grant that my colleague Dr. Vadaprampel got from the Florida Breast Cancer Foundation. And then thinking through what other sources that we've thought about applying for, but again have not at this point, is the Komen Foundation also has some outreach grants that they offer. So again, that's a potential area where one could secure this type funding for this type of work. CDC again has some initiatives in young breast cancer survivors, which could be another potential source of funding. And then local foundation grants would be another thing that could potentially fund this type of work. Looking at relationships to ongoing programs, again, we have had a lot of interactions with the Michigan program, specifically Deb Duquette, who is the Genomics coordinator there. And that group has identified a tool or has developed a tool to identify high-risk patients with hereditary breast and ovarian cancer, and we have disseminated it widely within our state to providers who provide genetic risk assessment as well. I know Michigan led the development of an NCHPEG module that we were part of on hereditary breast ovarian cancer, again, that we have actively tried to disseminate within our group. And then materials we have shared mainly has been our Black Women's brochure, which has been requested by Michigan, Oregon, and Georgia. So, again, I think there are many areas for partnership because there's really no point in reinventing the wheel. So that's where when we find other organizations that have things that we can use to disseminate within our group, we've really tried to do that. And in terms of acknowledgments, again, this wasn't just me that did it. There was a big team that we have that have been doing this, including our very involved community advisory panel, which actually includes one of the speakers that will be speaking in a few minutes, Dr. Sue Friedman. So thank you. I think we're going to take questions at the end.
All right, so good afternoon, everyone. This is Virginia Warren, and I manage the Breast and Cervical Cancer Early Detection Program in Arizona, and we call it the Well Woman Health Check Program. Now, the National Breast and Cervical Cancer Early Detection Program, and you go to the first slide now, Andrew, has 23 years of service under its belt, and they've gathered data to show the excellence in care provided through this program. But just to give you a sense of the size of the program, they've served more than 4.3 million women over this time. They've provided more than 10.7 million breast and cervical cancer screening exams, 5.2 million of those being mammograms and 5.2 million being Pap tests. So out of that group, they've diagnosed 56,000 breast cancers and 3,200 cervical cancers. So what they've done is put in place all across the country an infrastructure focused on cancer screening, breast and cervical. It's in every state, some tribes, and most territories. So you've got an infrastructure in place that's focused on cancer. It's focused on case managing the abnormals to early diagnosis and then tracking the implementation of treatment if necessary. It's a program focused on quality and measurement of that quality. However, with that said, I'm going to say that the programs do so much more than screening. We're responsible for actually teaching our providers how to increase their screening rate. We're responsible for making sure they provide appropriate and timely services. I'll give an example of that. If we have a patient that a doctor sees and does a clinical breast exam, finds a discrete palpable mass, and does not use the appropriate follow-up, it's our responsibility to provide education about the appropriate follow-up, the appropriate algorithms for a discrete palpable mass, and then monitoring the provider to ensure that the services are provided appropriately. 100% of the patients that we serve within the program are audited every 6 months by CDC. We submit the identified data to CDC, and they give us a report card on how well we've done. And the report card can be very specific. And again, I'll use the discrete palpable mass measure. For example, they can say, Virginia, you've had 4 patients, and it looks like they're probably from the same clinic that did not have appropriate follow-up to a discrete palpable mass. Tell us, why did that happen, and what are you doing about it? So they really do evaluate the data and give us guidance, but they do expect us to work with the providers and educate them. So we educate the providers, we educate the patients, we educate them about the need to be screened and how to advocate for their own health. So we're constantly looking at quality improvement process, and we do all of our work through very strong, well-developed partnerships. Partnerships with community health centers, partnerships with Komen, partnerships with provider groups, with oncologists, with cancer centers. We can't get our work done without those partnerships. So all across the country, you've got this very strong infrastructure in place. They're already working with providers on quality improvement. Each state, okay, so we all have the infrastructure in every state. So what I would propose is that the education, provider education and patient education regarding genomics be something that is collaborated on with this national network. The infrastructure is there. The network is very interested in this. When you look at genomics and the steps that can be taken for prevention, it's basically another tool in the toolkit that we can use to reduce the burden of cancer in our states. And that's what the breast and cervical cancer early detection programs are looking at. So the network is there. There just needs to be the ask and the collaboration between the genomics piece and the breast and cervical early detection programs. And I'm sure that in some states that's already happening. But really when the last FOA came out from CDC around genomics, it was really educational for me just to read the funding announcement, because I had not heard the specifics of the detail such as they were presented earlier in this webinar until I read the FOA. So the ACA's impact, Affordable Care Act's impact on the breast and cervical program, it varies by state. We had a webinar yesterday and all the states participated, and every state's experiencing something different, but most of the states are experiencing reduced screening. This means they can put their efforts to other things targeting reduction of cancer in their state. So it varies by state. Long-term, the programs are focused on quality improvement and systems change, working with FQHCs to increase their screening rates, and working with providers to improve the timeliness of their follow-up following an abnormal being detected. So for all of our contractors in Arizona, an example of this systems change is within 30 days of signing a contract with us, they have to tell us what their baseline screening rates are for breast and cervical cancer. And then we track that year to year and expect to see improvement through a Plan, Do, Study, Act type of model that we use. So what I propose is that there is collaboration potential. That's the next slide, Andrew. There is collaboration potential between the genomics side and the NBCC EDP and its grantees, all the way down to the providers. So this collaboration could also exist on the same sorts of issues within the colorectal cancer control program. But that program's only in 25 states and with, I think, another 4 tribes. So there's collaboration. We're all focused on the same thing, reducing the burden of cancer. And I think the time for collaboration is probably right now. And that's it, and we'll take questions at the end.
Thank you. I want to thank the organizers for inviting me. I'm going to change gears a little bit and talk more from the consumer perspective and talk about BRCA and HBOC and public health. So, you know, I was asked to speak a little bit about what it's like to live with BRCA, and I'm going to give you a little bit of the perspective from the patient side of things. So, you know, we really see at FORCE 2 somewhat distinct groups, and we actually see more than 2, but one way that we can look at the community we serve is in 2 different types of groups. There are the survivors. So these are people who have already been diagnosed with a cancer, and for these people, BRCA testing can have implications for themselves and for their family members. So there are some new clinical trials and emerging therapeutics that are being looked at specifically to see if they benefit people who have a germline BRCA mutation. So one of the most studied is something called PARP inhibitors. So knowing that someone has a mutation at the time of diagnosis may help them qualify for a clinical trial. And then, as mentioned before by Cecilia, it has implications for blood relatives and their cancer risk as well. And then it may affect follow-up and preventive cancer for a new primary cancer. So just because you had cancer once doesn't mean lightning won't strike twice, and especially in a mutation carrier, the risk for a second primary, and especially in females, is really, really high. In addition, if you look at breast cancer survivors, so people who have specifically been diagnosed with breast cancer, having and knowing your mutation status can affect surgical decisions at the time that they're choosing whether to have a lumpectomy or a mastectomy. It may impact their decision. For people diagnosed with ovarian cancer right now, knowing you have a mutation doesn't necessarily impact treatment. As I said, it does impact access to clinical trials, but there is some evidence that it may affect survival and prognosis. And in prostate cancer, the same, but in a different way. So there is some emerging evidence that men who have prostate cancer who have a BRCA mutation may have a more aggressive type, and that's especially been associated with BRCA2. So it has implications for survivors. But then we have this group of people who are high risk for cancer, and they don't have a diagnosis of cancer, what the healthcare community calls unaffected carriers, and we coined the term previvor for survivor of a predisposition to cancer, because we learned early on in the days of force that this was a community that really had unique needs. They were being somewhat marginalized. They had some commonalities with people who had a cancer diagnosis. Some of the medical interventions, such as being offered tamoxifen or undergoing mastectomy or removal of the ovaries and tubes, are similar to things that are offered to people with cancer, and yet they don't have cancer. And so sometimes those people would go to like a cancer support group for resources, and here at least you don't have cancer, you should be grateful. And you know, although many people in the community are grateful to know about this information up front, they don't necessarily come into it with that feeling, and they have their own support needs and the needs for resources in order to make informed decisions. And on the other side, sometimes because they don't have a diagnosis, especially in the general population, sometimes in the media, you'll see people say it's an overreaction, you know, especially prophylactic surgery. And, you know, we have many cases that we've seen in the media and other examples, you know, from the general population where people are like, what, you know, what are you going to remove next? Your arms, your legs, and, you know, really taking things to an extreme that really doesn't relate to the evidence and isn't helpful for this community. And there are health and psychosocial concerns that are faced by previvors that are different than the trade-offs for survivors. And some of these trade-offs are things like, you know, having risk-reducing surgery versus surveillance, where you may end up undergoing a lot of biopsies, that living with fear. Everybody has a different tolerance for living with that risk and living with fear, and some people choose the more aggressive approach, which is risk-reducing surgery. For those women who remove their ovaries before menopause, many of them have health concerns that are associated with early menopause. And then there's the hereditary aspects that impact family planning. When should you remove your ovaries? What if you want more children? And it affects family dynamics as well, because normally your family is your support system, but someone who's high risk and tests positive for a mutation may not feel comfortable getting support from a family member who's going through cancer treatment. It definitely has effects on the family dynamics. And these are just some quotes from people. One of the reasons that we developed the term previvor was from this perspective: I need a label. This is one of our members who posted on our message board, what am I? I lost my mom at a young age to cancer. I lost my breast to cancer. I sacrificed my fertility to prevent cancer, but I don't have cancer. And, you know, some of the things that we hear, these are real from members of our community. One woman said, you know, it's tempting to remove my ovaries, but, you know, she's concerned about the sexual side effects of young menopause. And again, these are people who don't have manifest disease making these decisions, and it, you know, it becomes a challenge. Someone else said, you know, I may not have cancer, but I know cancer, which really speaks to the fact that this is a population of people who are very impacted by this cancer risk and what it's meant for themselves and their families. So I want to talk a little bit, I know it's already been covered, about the importance of genetic counseling. This is something that we feel strongly about at Force. It's really difficult to make an informed decision if you're not getting information, the most up-to-date and credible information. So as it was suggested before, that the guidelines say that genetic counseling should happen before genetic testing and after genetic testing. Both are important. Genetics is becoming more complicated. There are new panel tests that are being offered, and many of them are not, contain genes in them that aren't as associated with clinical utility as BRCA. So there's a lot of emerging and new information. It's really hard for consumers to make these decisions that are going to impact their life, their quality of life, and their health, in a vacuum. So it's important that they get the most up-to-date information. And, we've had some examples of when things have gone awry, when people didn't have access to genetic expertise and what can happen. And, one was a high-profile article in Bloomberg where a woman was diagnosed with breast cancer. She had had testing. Her test had been positive. It was misinterpreted by her doctor, and he told her she was negative. And then she went on later to have a second diagnosis, and that, that's challenging, and it affects people's health. And then another example we had of a woman and her family who were all tested. They had a variant that was, communicated to them as a mutation, and this woman underwent an irreversible surgery based on a test result. So this was her post on our message board. So, it's really important. Genetic counseling is available in person, via telemedicine, and by telephone. And, there's been a lot of research on it that it can be effective, and that's a way to improve access to care. So most people in the United States do have access to qualified experts, and they should be aware of what standard of care is and have access to it. So I want to talk a little bit about advocacy and policy. Just a few of the health provisions and laws around or that impact genetic counseling and testing. Most people are aware of GINA, that went into full effect in 2009, that prohibits discrimination in health insurance and employment for people who have risk. And it does not apply to people with manifest disease. So really this had protection implications mostly for the pre-vivor community. In addition, the Affordable Care Act, I'm sorry that the information is off my slide, but it really kind of closed the loop in that it prohibits health insurances from using pre-existing conditions to deny coverage or determine coverage. In addition to that, I wanted to talk a little bit about the link between the Patient Protection Affordable Care Act and the USPSTF guidelines. So the United States Preventive Services Task Force guidelines are written into the Affordable Care Act, saying that preventive services that have received a letter grade B or higher must be covered by insurance companies without any cost sharing. So, the fact that, as was mentioned before, the USPSTF has guidelines that talk to genetic counseling and testing means that more people do have access to genetic counseling and testing and do not have to pay out of pocket for it if they meet the USPSTF guidelines. But the guidelines are not complete, and we've expressed some of the concerns about the limitations of the guidelines, and I'll talk to you about that in the next slide. So there are some gaps. Currently, the USPSTF guidelines say that there's coverage for genetic counseling and testing for people who have the family history suggestive of a BRCA mutation. However, the guidelines do exclude people who have already been diagnosed with cancer, which is a problem, especially because, for example, someone who's been diagnosed with breast cancer is now also at high risk for ovarian cancer, and genetic counseling and testing could have preventive implications for them. However, because of how it's written, and most insurances will still cover it, but they could have a large out-of-pocket or copay. And it would probably take a legislative action to change that. Other gaps in coverage, Medicare will cover BRCA testing only in women with cancer, so there's a gap for women without cancer. Right now, there's no coverage for genetic counseling and testing in men, under the USPSTF guidelines. There is a study looking at things like the impact of PSA screening on survival in men with mutations, and when that study is completed, we'll probably see more coverage, and hopefully USPSTF will change their guidelines to reflect that. And there's no coverage, at least it's not written into USPSTF guidelines for genetic counseling and testing for Lynch or other hereditary syndromes. So that's a real gap, and that will probably take either legislative action or introduction as a topic for the USPSTF to consider. So I just want to talk a minute about research and a little bit about CORENET, which was funded through the Affordable Care Act, the National Patient-Centered Clinical Research Network. CORENET, it's a national platform for conducting large-scale patient-centered outcomes research. The goal is to connect personal health information and data and outcomes for 70 million Americans in order to conduct large-scale representative patient-centered outcomes research studies. And hereditary breast and ovarian cancer is one of the diseases that's focused on in phase 1 of the CORENET through the ABOUT network, which is ABOUT is a patient-powered research network that is the research is designed and conducted by people from within the HBOC community, and our idea is to turn real patients' real-world experiences and decision-making and figure out where the gaps are in guidelines and information to really turn that into patient-centered outcome rigorous research so that we can give people some answers to their questions about what happens, what are the outcomes for people who choose one intervention over another intervention. So ABOUT Network Force is one of the co-PIs in this effort. And then just quickly about the resources, these are the programs that we have through FORCE. FORCE is facingourrisk.org, so all of these are available on our website. We have a toll-free helpline, we have an annual conference, and we have print materials for people.
I'm going to talk very briefly about public health, about HBOC resources. First thing I want to mention is this HBOC is your patient at high risk. I think that Tuya also mentioned this. It's an educational model that offers free continuing medical education units for primary care providers, and it also has many additional resources. And it was created in collaboration between the Michigan Department of Community Health, the Oregon Department of Health, Georgia Department of Health, and the National Coalition for Health Professional Education and Genetics, otherwise known as NICHPEG, and the Division of Cancer Prevention and Control in the CDC. And it's now hosted at the Jackson Lab. And then speaking of the Jackson Lab, they also offer a family history for cancer risk assessment, testing, and management module that has CMEs as well, and it's an online program that aims to increase the skill in identifying and managing individuals at increased risk of cancer based on family health history risk assessment. And as we've heard, that's a very important component of HBOC. Again, NICHPEG, hosted at the Jackson Laboratory, has other resources as well. So that's something that you really should try and make time to check out. And we've been talking a lot about the USPSTF recommendations. In them, they highlight 5 tools that aid in identifying high-risk women in order to refer them for genetic counseling. And these 5 tools are here on the screen. And the USPSTF identifies both the BRCA tool that Cecilia introduced and the FHS-7 as the simplest and quickest to administer. Here's the BRCA tool that Cecilia talked about briefly. And it is an online tool. It's very easy to access and use. And the FHS-7 is simply a series of 7 questions. And if any one of them is answered positive, then that should initiate a referral to a genetic specialist. Now, Tuya Paul's group out of the Moffitt Center has created a cancer registry for BRCA1 and BRCA2 mutations. And so you can connect with her for more information on that as a research scientist or for surveillance activities. But it's also a really good thing for patients. So if any of your patients are interested in joining a registry, that can get them updates with opportunities to contribute to collaborations on hereditary cancer or other sorts of information about every 6 months. Now, one of the last two pieces of information that I want to plug is the CDC Office of Public Health Genomics. They are a great resource, and they also have a clickable map that shows what genomic activities are happening in each state. So you can check out the specific state that you're in to see what's going on, or other states if you've heard about any interesting activities. Now, Tuya talked a little bit about her brochure. It really is great, and they are sharing it freely with people. So if you're interested in providing that as a resource to patients or people who may be at high risk for HBOC, then that is available to you. And finally, here's a list of 5 other resources that I think really are worth. So I'm going to start with the first question, which is, I recently saw an Ashkenazi male patient with a strong family history of breast cancer at a young age on one side of his family. I suggested BRCA testing, and he came back positive for a common founder mutation. He has 2 teenage daughters. How often are doctors encouraged to counsel for and perform BRCA screening on men with a strongly suggestive family and ethnic history? Cecilia, do you want to take that question?
Sure. So that was a very, very appropriate approach to identifying a high-risk family. Ideally, we would try to first look at an individual in the family that has had the cancer, because that is going to be more informative for the rest of the family. But in a situation of Ashkenazi Jewish descent, because of the high frequency of mutations in this population, it is reasonable to go ahead in that circumstance if you cannot identify an affected family member. Really, any male with breast cancer should be offered genetic counseling and BRCA testing. And again, males should have their family histories identified. If it's a high-risk family, refer them for genetic counseling. And if the family, meets criteria, then offer testing. If you, again, are not able to first identify a mutation in someone affected in the family.
Great, thank you. And it looks like one more.
I would add is the teenage daughters. I don't think any of us would recommend testing for them until they're adults and can choose for themselves, and usually around the age of 25 would be what was recommended for kids.
That's a very good point. Thank you. Another question, specifically for Cecilia, is your BRAS screening tool based on the NCCN criteria for genetic evaluation?
No, it is not. It should be noted that the NCCN criteria actually have never been validated against genetic testing. The criteria are very broad, and they are are going to identify a lot of women at risk. So for screening tool purposes in the general population, the BRAS tool is going to have fewer false positives, so to speak. It obviously meets some of the NCCN, but for example, a single case of breast cancer under 45 in the family is not going to flag it positive, and it does not have the capability of flagging triple negative. So it's a more useful tool for individuals with family history than individuals with necessarily a personal history.
Great, thank you. Virginia, I have a question for you. How do you recommend starting the connection between breast and cervical screening and genomics programs?
All right. First, introduce yourself to the program director in your state. Okay, there's someone managing your breast and cervical program in your state. Introduce yourselves, sit down, and start talking about it. And then I would start, most of these programs have contractors. And for example, in the state of Arizona, I have several very strong, very proactive contractors. I would bring them to the table, helping me work with the genomics person to plan our approach. My guess is it would start with provider education. Provider education is something that's greatly needed. I'm going to speak for Arizona alone because I don't want to offend anyone, but I will state that you cannot assume that providers know all the changes that have happened within USPSTF, and you cannot expect them to know all the changes required under ACA. So when you educate about those changes and the recommendations, you'll find that a lot of them just didn't know it, and that's why they weren't doing it. So that's where I would start, with getting to know the program director, pulling in key contractors or stakeholders, and moving forward from there.
Great, thank you. Another question came in asking for us to please indicate how to identify qualified genetic counselors available for teleconsulting directly by an individual. Are lists readily available, and if so, where? So I'll point out let's see, sorry, I lost my train of thought. I'll point out the National Society of Genetic Counselors, which has a list of genetic counselors by state. And it doesn't necessarily, I think, tell who is doing telecommuting services, but at least is a place to start. Is anyone else aware of the specific question about telecommuting?
Yes. So this is Sue Freeman, and there's also a network of genetic counselors called Informed Medical Decisions, and they have genetic counselors, board-certified genetic counselors available by telephone, and I think it's informeddna.com.
Right. Great, thank you.
And there are others and more emerging in terms of telemedicine and genetic counseling. So even Googling telemedicine or telegenetic counseling will help you find someone. The main thing you want to look for is to make sure that they are using board-certified genetic counselors.
All right. Here's a question that came in, and you know, a lot of us may feel some passion around this, but perhaps, Sue, you'll have a perspective. The commenter says that I feel that we need lawsuits by patients with inappropriate testing or interpretation of results to increase the use of providers of genetic services. Does your organization suggest lawsuits?
So we don't give legal advice. But we do educate people about what is standard of care, as well as what is not standard of care. And certainly, I think that individuals who learn they have received below standard of care, that may be an avenue that they would consider following. You know, from a personal experience, as someone who you know, because of my diagnosis and not because of genetic testing, had actually been improperly staged, leading to a recurrence and more treatment, and following the path of knowing what it means to enter into a lawsuit. It is really no small task to do that. So, you know, I mean, I think that people need to talk to legal counsel. I do feel that, you know, it was clear to us, and we went to the FDA with our concerns that that people were not being given up-to-date, credible information, and there was somewhat, we felt, an encouragement against genetic counseling through some of the more aggressive marketing practices that happened in the past, and we had testified about it. And, you know, we do what we can to educate people.
I would also comment, this is Cecilia Bellcross, that there are some current issues that are limiting access to genetic counselors, and one is that we are not currently recognized by Medicaid, Medicare services as providers, and so that in some cases can limit access. And then we are working state by state to obtain licensure, and that's easier in some states than others. Again, we have board certification and so forth, but we are pushing forward with these other state and federal issues to try to increase access.
Great, thank you. And a participant wrote in that NSGC, the National Society for Genetic Counseling website, does indicate which genetic counselor is available to provide telemedicine, so that's another helpful resource. And to Virginia, you mentioned that Well Woman's Health Check has an algorithm for follow-up and monitoring of provider services. Could you please share with us the types or categories of services that are followed?
All right, anytime a woman is screened and there's an abnormal result, such as a discrete palpable mass, we have an algorithm that includes all the follow-up. If you have a retracted nipple, it's a very similar algorithm. We use the California-based algorithms that they have posted to their website. They also can be found on our website, which is wellwomanhealthcheck.org. And then it's under the tab on the left side that says Data, Manual, Reports, and Forms. And so we do have algorithms for all of the services, all of the things that you can have as a finding on the breast side, and the same on the cervical side. And on the cervical side, we use the ASCCP guidelines.
Great, thank you. Aside from Ashkenazi Jewish population, where is good data on how the frequencies of different BRCA1 and BRCA2 mutations vary between ethnicities?
Well, we do know there are some other populations where there are founder mutations, such as in the Jewish population, Iceland, and I know some populations in Europe. And Tuya may be able to answer this better. I really don't think we have a real good handle on the incidence, because that would really require population-based screening in different populations to ascertain what the actual, incidence is. So it's estimated from the number of individuals we've tested and tested positive compared to those who tested negative. But the estimates, again, are somewhere between 1 in 300 and 1 in 500 for individuals of non-Jewish descent, but there are other founder populations, Iceland, and I think there's a Polish mutation and so forth. So it's less helpful, though, in the United States, other than the Jewish ancestry. And then you heard, of course, from Tuya there, looking at the incidence in African Americans, which may differ.
Thank you, Cecilia. Another technical question that you might or might not be able to answer off the top of your head is whether or not the early data that was suggesting increased risk of gastric cancer related to HBOC, whether that's been discredited or not.
At this point in time, we are not quoting or suggesting an increased risk for gastric cancer. That data was a little spurious and it has not been confirmed, so that is not included in the list of cancers.
Great, thank you. I think we have time for one last question, and I'm not actually sure. Let's see. Sorry. Let's see. So the question is, for individuals who cannot get genetic counseling covered through health insurance, would you ever suggest direct-to-consumer genetic counseling? And what dangers do you foresee following that path? And I think I want to step in and answer that first. we're always advising that a person consult a genetic specialist before they get testing. That's a guarantee the best care that you will receive. And many states are working to increase and improve coverage for genetic testing when it's appropriate. And so it may actually be easier at this point than people realize to get coverage. In addition, individuals can pay for those services out of pocket and don't necessarily need to go the direct to consumer testing route.
So
does
just
want to add?
Yeah, I would add that, at this point, if I interpreted the question right, it was sort of direct-to-consumer genetic counseling. There is not available right now direct-to-consumer BRCA 1 and 2 testing without involvement of a healthcare provider. There is a new genetic counseling service that is soon to be launched through Doctor on Demand, where there is a relatively nominal fee to have telecounseling by a board-certified genetic counselor. And the person pays out of pocket, but I believe it's something like $60 as opposed to what you might have to pay out of pocket through an institution. And again, these are board-certified genetic counselors, so that should increase access to counseling as well. And that's Doctor on Demand.
So, this is Sue, and I just wanted to say one other thing about that, because we get a lot of calls. And sometimes it is a matter of educating the insurance companies, which I know can be a pain. But even the insurance companies aren't all aware of what's required through some of the new legislation. So I would encourage people to appeal and even start by many genetic counselors are very amenable to contact, and the National Society of Genetic Counselors does list the contact information for many of them. I'm not trying to overwhelm the genetic counselors out there, but many are open to it, and even a phone call could help you find out if indeed that is true, that it's not covered through insurance. I mean, I think whenever possible, if it is a covered service, we should do what we can to make sure it's covered by the people who are charged with paying for it. So.
Yeah, and I would agree. And often genetic counselors help facilitate the process of working with the insurance company to obtain coverage for both counseling and testing.
Well, that is wonderful information. Thank you so much to our presenters for what they presented and also for answering these good questions that followed. We went a little over, so I'm going to say that the webinar is now officially ended. Thank you so much, everyone, for your attendance and your participation. Take care.
Thank you.
Thank you.
Thank you, Summer and Andrew, as well.